no rush at the moment.
Okay, I think we should be ready to start in about 2 minutes. You should all be able to, hi Joyce.
Hi.
You should all be able to control the mute and
Okay,
unmute.
I think we should be ready to start in about 2 minutes.
Sorry, the live stream was going on in the background. I had to close it. So you should have control over the mute function for yourself. So mute and unmute yourself as you need when we are presenting. Otherwise, we all sit. Y'all are so quiet. It's good or bad.
Hopefully this session is as interactive as the first one.
Yeah, we couldn't get people to stop talking in the first one. It was
Yeah.
it was really good. Okay. Can we start? Okay, I'm going to admit everyone in and we should have a start. Hello, everyone, and welcome to this session. Thank you for joining us again. If you've joined us in the earlier session, if not, welcome for the first time. We are still in the Anatomy Festival, and we are focusing this symposium on anatomy being inclusive, diverse, and accessible. We've got a fantastic lineup of people, and so we will start almost immediately. And for those of you who were in the first session, you will remember what a lively discussion we had about anatomy being inclusive, diverse, and accessible. I am delighted to be joining you from Sydney, and we've had such a beautiful day today, and I hope that you enjoyed something special in your place as well. As is custom for us in our country, when we start up a meeting, we usually acknowledge the people who were the traditional custodians from the land that we are on. I'm going to do that and invite you, if there is a similar tradition in your country, to do that by dropping that acknowledgement into the chat line. So I am joining you from Birribirri Gull land. These are the unceded lands of the traditional custodians of this place, the First Nations people, and I want to pay my respects to them and any elders, both past and present, who may be joining us today. It's a wonderful thing that we do at the beginning of each meeting, just to make sure that we are inclusive and accessible to people that are in our community. I am joining you, of course, from Sydney, and so is my colleague Joyce Eldhard, who is here on the call. And so from time to time, you may get a message from her, and she's just helping us manage all of the things in the background and also host this today. Joyce is a younger generation of anatomists who is challenging us to do things differently. And if you have younger anatomists in your areas, you would be wonderfully pleased to see how much they're thinking about anatomy being diverse, inclusive, and accessible. We have several presentations this morning or evening or midday, depending on where you are. The first of our presentations is going to be by Professor Bernard Moxham, and he's going to talk about anatomy and sexuality. Then Professor Beverly Kramer is going to present a masterclass, but just in between those two long sessions, Jenny Hayes is going to do a fantastic presentation for us on anatomy textbooks and open our eyes to seeing some things we may or may not have noticed before. And then at the very end, we have a presentation from a museum curator who's going to talk to us about being inclusive in museum practice. So without any further comments from me, I'm going to introduce the first speaker. And those of you who have been in the community of anatomy know him very well. Professor Bernard Moxham, I tried to read his CV and it was so long and so many accomplishments. So I'm just going to pick a few, and I'm sure you probably know much more than I do. So Professor Moxham has been the professor of anatomy at Cardiff. He was the Dean of Health and Life Sciences at Cardiff, as well as the Deputy Director of the School of Biosciences. Most of us actually know him as the past president of the International Federation of Associations of Anatomists, and he was also the president of the Anatomical Society of Great Britain and Ireland and the European Federation of Experimental Morphology. So Professor Moxham, thank you for joining us today, and I'll hand over to you for the first presentation.
Well, thank you very much for the invitation, and good morning, good afternoon, good evening to you all. Thank you very much for coming. So this is anatomy and sexism, not sexuality. I call these talks provocations. I seem to be doing a lot of provocations as I've retired, rather than talks, because what I intend to do is to try and provoke you to think slightly differently to the way in which traditionally we've always thought. And in this case, I'm going to be concentrating on the kind of activities that have been going on over the past 5 years with regard to the use of terms which are derived from pudere, which is Latin related to being ashamed, having shame, shame related. And you can see some of the terms which we're all familiar with, from pudenda through to the clinical pudendal block, which come from those pudere Latin terms. Now the structure, I'm going to start with a definition and a couple of hypotheses. I'm going to say why pudere related terms need changing. There's going to be a contextual history which will go beyond pudere just to show where sexism exists in anatomy. What has been done and what still needs to be done, because things have not been completed as yet. Then I'm going to say how, since the terminology group have made some changes, there have been quite a lot of publications which have been attacking the fact that changes have occurred. So I'm going to go through those arguments and point out whether they're fallacious or not. And then we'll have a summary right at the end. Okay, so sexism. What's the definition? Well, the one which is normally accepted, and there are variations, of course, is that they are all those attitudes and actions which relegate women to a secondary and inferior status in society. The hypotheses that I'm going to be developing, you may not particularly like them, is that unfortunately both anatomists and medical students do not perceive sexism within their discipline and are ambivalent with regard to matters relating to equality and diversity. And then in relation to that, but also going back to the pudere issue, pudere related terms should be changed, and they should be changed for scientific, biological, as well as sexist reasons. Now, what are the reasons for changing terms related to pudere? There are three reasons. They are unscientific. Most anatomical terms, certainly those which we would wish to pursue, are related to some descriptive aspect. So there's descriptive objectivity. So it might be that the location, the attachment, the function, etc., will actually dictate the name of the anatomical structure. Pudere terms are the only terms which relate to a moral stance. And I think that is wrong. We don't need morality in a scientific discipline, certainly not in the 21st century. That brings us on to the second reason. As biologists, why should we be ashamed of absolutely important functions in the perineum, micturition, defecation, conception, parturition, and sexual well-being are important functions without which the species wouldn't even exist, let alone the individual. So there's no reason for having shame biologically. And thirdly, the terms do have sexist connotations. I know that traditionally pudenda can be used for males and females, but that is not the way the terms have developed. And certainly in English, they are related more to females than to males. And as an example of that, just looking in Gray's, this is the 39th edition, I hope they've changed it since. When you look up pudenda, it says, for pudenda, see vulva. So those are the reasons for wanting pudere terms to be changed. Now the concept, the contextual aspects. Going back to the 60s, in 1966, I became an undergraduate student at Bristol University. And I can remember being in a very large lecture theatre with medics and dental students and hearing a lecture, an introductory lecture by quite a distinguished anatomy professor. And he provided some very good advice, namely that if you're learning anatomy, please try and work out what the terms mean, because it will help you understand anatomy much better. So he went through a few terms and then he came to pudenda. And he said, it comes from pudere, the Latin meaning to be ashamed. And as we all know, you females should be very ashamed of your pudenda. And everybody laughed. There were very few females in the audience in those days, and everybody laughed. But that stuck with me. I thought, this isn't quite right, is it? So we move on 30 years now till the 90s, the late 90s, and the early 200s, when I was professor of anatomy at Cardiff. And when I was visited by one of the lecturers in English, creative writing, who subsequently became a PhD student with me. And she was doing interviews with various people, including a lot of anatomists, to see whether they understood much about female anatomy. That was Susan Morgan. And in particular, she was concerned as to whether people knew of the work of the Australian neurologist Helen O'Connell, who had written extensively about female reproductive anatomy. She showed that typical textbooks description do not describe male reproductive, that should be female, that do not describe female reproductive anatomy fully. They include inaccuracies and mainly only emphasize differences between males and females. I was ashamed because I said I didn't really know of O'Connell's work. But fortunately, when I got to talk with one of the academics who was lecturing our students on the female reproductive system, she was well aware of O'Connell, so our students were getting the right message, but I wasn't aware of this particular work. So on the basis of that interview, I said to Susan Morgan, we really ought to do some studies to find out just how much students and anatomists know about sexuality and sexism within anatomy and within medicine in general. So we started a series of studies in order to investigate this. So one of the papers was published in the Journal of Anatomy following a conference at Cardiff. Sexism and Anatomy as discerned in textbooks and as perceived by medical students at Cardiff University and at the University of Paris Descartes. And as you can see, this was done with Susan Morgan, Odile Plaisant, Baptiste Lignier, and myself. A subsequent paper with the same authors was Sexism with Anatomy as perceived by professional anatomists and in comparison with the perceptions of medical students. So what did we find? Firstly, in relation to textbooks, we may be hearing more about this later on. We looked at all the common textbooks used across the world. And of the two most popular surface anatomy books, Lumley showed very few images of female anatomy, excepting for the breast and the perineum. Whereas Backhouse and Hutchings did at least show equal numbers of male and female images. For Gray's anatomy, male anatomy predominated, including most surface anatomy images. However, in contrast to the 39th edition, in the 40th edition, the illustrations of female genitalia were no longer old-fashioned and frankly unpleasant in the 39th edition. But still the descriptions of female anatomy were incomplete and were mainly described in relation to male anatomy. Moore and Snell preferenced male anatomy, both in the text and in the imagery. But Gray's Anatomy for Students, certainly in the second edition, had equal numbers of male and female images. So they made a great effort to ensure that there was diversity in their imagery, although a lot of the clinical cases that they had in the book had clinical cases which were often associated with women. So in conclusion from just that study, we realized that textbooks really weren't showing the diversity that was required. And this applied not just to male and females, but also to ethnic differences as well. Fortunately, textbooks and publishers seem to be changing. Elsevier, with whom I have a textbook, have recently contacted me in order to produce a new edition of one of my books, and we discussed the need for more diversity within the imagery. Then we went on to ask students various questions, and obviously one of the questions was, did you see anything within the textbooks would suggest to you that there was an imbalance, that there was sexism? And we're looking at Cardiff data here, and males and females, females and males. And as you can see, the top one here, that is for people who had little sympathy with gender-related politics, those who had some sympathy in the middle, and then people who were very sympathetic to gender issues. But regardless of their predilections towards gender issues, across the board, they really didn't see much in terms of the textbooks being lacking gender diversity, excepting for the females who were, you could broadly describe as feminist. And there you can see there's a 40% of the people then did discern that there was a lack of diversity within the imagery. With regard to other questions, this is for Cardiff. 60% of the students that filled in our survey admitted they had some sympathy with gender politics or with feminism. And 16% of males declared themselves unsympathetic, with 26% of females declaring themselves unsympathetic. When we asked them the question, do you believe that medicine is male dominated? Generally, whether there was some or whether there was an extensive male domination, most people accepted that there was a male domination within medicine. The exception, again, as you can see here, is for the males who had little or just some sympathy with gender politics, who did not believe that medicine was male dominated. We asked them what branches of medicine females were best suited for. The answer we really wanted is that they are suited for all branches of medicine. But this is what we got commonly: obstetrics and gynecology, general practice, dermatology, psychiatry, nursing, not medicine, and some made facetious comments which weren't meant in any way to be humorous, because other parts of their questionnaires indicated that they actually believed in these kind of things. Some people would say things like sandwich making. We then gave them some mnemonics, and this is the results for a sexually derived mnemonic for the superior orbital fissure and the structures passing through the superior orbital fissure. We asked them whether they thought there was concern. Across the board, no concern with the mnemonics, despite the fact that all the mnemonics were sexual and related to females. In the interviews that Susan Morgan gave to anatomists, one anatomist quoted, "A female student objected to a mnemonic with sexual content, and this annoyed me, as it carried no menace and has been used for 2 centuries. And those kind of comments came out quite frequently in the interviews that Susan Morgan conducted. We then asked the students to assess various imageries as to whether there was a gender bias. So here's one image in which a male surgeon is rescuing a nude female patient who is being gripped by a skeleton representing death. Now, on a Likert scale of 0 to 5, anything over 2.5 would suggest to us that the students were aware that there was a problem with the imagery in terms of sexism. And in this image, you can see that only the students who are sympathetic to gender issues, whether it came from Paris, whether it came from Cardiff, whether it was male or female, but only the students who were sensitive to gender issues actually thought that this had a sexist basis. For the other images, which I'm going to show you, nobody discerned any sexism at all. So we have the very famous wax in Bologna, showing a female in a rather erotic pose, displaying her abdominal contents. None of that was seen to have any sexist intent. The image of the female vulva by Leonardo da Vinci, bearing in mind that he thought it was a disgusting part of human anatomy, and he couldn't understand how he could ever be born through that, to quote him. Again, they didn't discern the fact it was rather unpleasant as being sexist. Von Hagen's, again, a sexual pose, again, nothing. So the imagery didn't seem to affect the students at all. We asked a lot of questions. I'm not showing you all the details, but now we move on to some questions where we asked if we saw that there were inequalities happening in class, should the teachers intervene in any way? Only the female students who have sympathy with gender issues said that teachers should intervene in class if they see inequalities. Now we're talking about some often quite significant inequalities happening in class. I had to admonish a surgeon who was working in my dissecting room, who said to a table where there were lots of females, oh, move over and let the men do the dissection because they're going to be the surgeons and not you. So when the students were actually told, should we intervene in those circumstances, they said no, just the females who have sympathy with gender issues. And you can see that other people there are not really interested in us intervening. Should, in the anatomy course, gender issues be formally addressed? No, according to the students. So, in conclusion, from all that we studied, whilst the majority of medical students, and I have to say similar results were found for anatomists, whilst the majority of medical students have some sympathy with gender politics and issues, most students believe that there's male domination in medicine. They don't perceive gender bias in their textbooks. They do not require staff to deal with inequalities within the class. They don't find either the imagery or the mnemonics unacceptable. And overall, we concluded there was a mismatch between students' desire to avoid sexism and their awareness of sexism within their education. We urged anatomists to be alert to such issues in order to ameliorate any adverse effects during the students' education, regardless of what the students themselves felt. So that's the context. Students do not perceive sexism. They're not terribly worried by it. But should we therefore say, well, okay, then we shouldn't do anything about it? My answer is we should do something about it. We move on now to the pudere terms themselves. There's been a long history and struggle to get the Federative International Programme for Anatomical Terminology to make changes. I'm not going to go through the politics of it, but some changes have been accepted, but not all. As you can see from this list, and I'm sorry it's a little bit fuzzy, there have been changes to pudere terms, substituting instead terms relating to vulva. But what hasn't been changed are the terms relating to pudendal nerves and vessels, which seems to me illogical. You no longer have pudenda being accepted terminology, and yet adjectives relating to the nerves and vessels going to the region still have pudendal associated with them. And this was despite the fact that alternatives, reasonable alternatives, not radical alternatives, were presented to the terminology group, and it was not accepted. So here was the declaration from FIPAT in relation to that. Based on the published minutes, and later confirmed with attendees, this was attendees at the management group, of FIPAT, the group concluded that the 2016 meeting opposed pudendus and pudendum, but not pudendalis and pudendal. I have to say there are no published minutes because there hasn't been a meeting of the management committee subsequent to the 2016 meeting. So they've never been confirmed. And as for confirming with attendees, I don't think Beverly or myself were ever approached in order to confirm what the minutes should be. This is just to show you the letter I wrote to John Fraher, who was president at the time. I'm writing to you in anticipation that we can have a discussion at our FIPAT meeting in Germany about the suitability of continuing with terms pudenda and pudendal. Virtually all the terms used in gross anatomy are based on scientific criteria, location, attachments, function, etc. The terms pudenda and pudendal are non-scientific and being based upon an outmoded moral concept are not appropriate in contemporary society. Given also that pudenda are also often restricted to describing the female genitalia, the terms are also sexist. So there was no doubt that the meeting agreed that all terms relating to pudendere should be changed. So there are lots of reasons why pudere terms should not be changed according to the critics. And there have been a number of papers, and I'll be showing you some of those, that have criticized the change. Let's go through them in turn. Anatomists are not sexist. Well, I hope most aren't, but certainly from the surveys we did, there is a suspicion that there is at least implicit and rather hidden agenda sexism still existing. But here is something from one of the members of FIPAT, addressing the concerns of equality and diversity in anatomy. We are in 21st century now. As for gender equality, it is against the organization of nature and supreme creator. Male and female will always remain different from genetic material to physical form. Since the advent of civilization, females have had inherent sense, desire to cover their external genitalia, presumably not male. Even today, as model on sea beach, taking sunbathe in nightclubs, on the stage shows, however little a female wears, she keeps her external genitalia covered. It is inbuilt in the female limbic system and high up in cerebral cortex and the reticular formation. And then from Susan Morgan, different anatomists. Girls can only be GPs, so there's no point bothering with anatomy. Women need not study, but should marry. If females are less likely to be reported for disciplinary proceedings, this might be evidence that females are better fitted for medicine, but I cannot prove that this is a personality trait rather than a cultural phenomenon. Women may need to exceed the aggressiveness expressed by males in order to succeed. Many people trust more if answers come from a male. There are more successful male medical scientists in our present time. Traditional term. People are no longer know about its etymology, nor do they care. Well, in our survey, we actually asked the students about their attitudes towards terms relating to pudendere. And it's true. Students and anatomists rarely care about the term. So in that sense, it's right. They don't care, they don't know, whatever. Is this a sign that we shouldn't be changing? Or is it a sign, again, that there is an agenda within our discipline which needs bringing to the fore and which needs changing? Medical students do not perceive sexism within their discipline and are ambivalent to matters relating to equality and diversity. This is what this means. Pudenda refers to male as well as female anatomy. Certainly in its most traditional form, it did, but it doesn't these days. The Oxford Dictionary, persons' external genitalia, especially a woman's. Cambridge, the sexual organs, especially of a woman. Collins, the human external genital organs collectively, especially of a female. Webster's, the external genital organs of a human being and especially of a woman. We should adopt a conservative approach. We must not deal with radical changes. So here are two papers which take this particular point of view. And it must be said from Paul Neumann that he has pointed out that anatomical names should preferably be informative and have descriptive value, which clearly pudere terms do not have. But the terms that are being used instead of pudere terms are hardly radical. Vulva, genitalia, these are not radical terms. They're perfectly acceptable terms that have been around for centuries and clearly are better terms than pudere terms. So that doesn't apply. Modesty. In a recent paper, it's been pointed out that there are certain poses in classical sculpture, which is meant to show modesty. And therefore, pudere terms are related to modesty and not to shame. But of course, mean or could mean modesty, it's just the other side of the coin. If you have shame, you have to hide the shame and therefore have to show modesty, but it's still a display of shame. So to try and say that the terms really mean modesty and not shame is not only inaccurate, according to all the Latin scholars that I've approached, it also is trying to say that black is really white. Modesty is being shown in order to hide the shame. Sorry. Then we have saints. Apparently there are saints who have the name relating to pudere. But these saints were inventions. They were saints that were invented by monks in the 4th century. And there is nothing to indicate that there were particular saints with names relating to pudere who actually showed modesty and therefore show that the term pudere relates to modesty rather than shame. So in this paper by Zadilla, this was what he said at the end: the meaning of the root word of pudendum is that of modesty, respect, honor, virtue. Although somehow this meaning has been perverted. No. Pudere in classic Latin means shame, and it means extreme shame. In Roman society, if a person was accused of the shame related to pudere, it was regarded as the ultimate shame in that society. And all the Latin scholars and all the Latin historians that I've talked to are actually perplexed by the idea that the term pudere really means modesty, respect, honor, and virtue. Anyway, he goes on to say, and maximalized to equate to shame. The meaning has been perverted and maximalized to equate to shame and hence misconstrued. Indeed, the term has a positive connotation. The term pudere should therefore continue to be espoused by the anatomical community with renewed appreciation. In French, pudendal nerve is often referred to as nerf honteur, where honte equals a modern word in French for shame. It's quite explicit. Even if we don't see pudendal directly related to our modern language as being shame, in French, the word honteux relates very directly with the word used commonly to mean shame in their. And lastly, clinical use. It's no good anatomists making changes. Clinicians will never use them. They have their own ways of doing things. Well, if we follow that, of course, there's no point in us making any changes to anatomical terminology at all. We might as well say, well, that's it then. Let the clinicians get on with it. But actually, it's a false argument again. Because if you look at what is going on in the medical community, they are very concerned about equality and diversity, and gender equality and diversity. For example, the Lancet, one of the primary journals in medicine, has a very extensive policy document relating to equality and diversity and gender equality and diversity. So it's not true to say that we should not make these changes because of clinical usage. And lastly, isn't this a fuss about nothing? There are more important issues to deal with. Anyway, dealing with this matter will bring anatomy and anatomists and the IFA into disrepute. Well, we know there are lots of things going on in the world at the moment with regard to the role of the female in society, and they're very severe things. There's the Me Too generation, there's the issues about rape, and of course there's misogyny in general. But to say that the issue of whether we call something pudere is not exactly something which is missing in society. And here's an article in which I was interviewed from the New York Times about the use of pudere terms. And this got so many responses, it was regarded as the article of the month by the New York Times. So Rachel Gross, the journalist, has written this particular article following interviews with various people. It has been well shared in the society and people have views about it. So it's not a small thing. And anyway, even if it is small, it is something that we as anatomists can do. We may not be able to do something very big with regard to Me Too, but we can make sure our discipline is more equal and more diverse. So lastly, a paper by Kalshik, changes of anatomical terminology must be deliberate. The female external genitalia, notice the title doesn't say the female external pudenda. This is the article where he said that, I'm sorry, I can't read all of this. So he said that it will bring discredit upon FIPAT, the IFA, anatomy in general, and anatomists amongst clinicians. Now, certainly, we have responded on the website of the IFA, so I read you what our response is. Certainly, if radically made up terms have been invented, there might be some justification in the accusation, because the accusation is that we use impetuous and radical terms. However, changing pudere-related terms to those related to genitalia or vulva is hardly radical, such terms being readily understood and employed in medical and scientific circles for centuries. We go on. There are already issues concerning the esteem of anatomy and anatomists amongst many who erroneously consider our discipline intrinsically traditional, old-fashioned, unadventurous, and fuddy-duddy, and who also claim that there is nothing more to be discovered in anatomy. Maybe those who do not want to come into modern times in order to make simple changes to inappropriate terms are indignant. But the IFAA does not want our esteem to be further eroded by failure to update in clearly minor but important ways antediluvian terms in order to ensure that our terminologies reflect contemporary concerns and issues, moral, scientific, and biological. So, in terms of disrepute, who is responsible for bringing the IFA, anatomists, anatomy into disrepute in these terms? Is it those of us who stick our heads above the parapet and say something is wrong and should be changed? Is it those who dispute the need for doing that? Or is it those who bury their heads in the sand and wish the whole thing would go away? Thank you for your attention. And if there are any questions or debate, we can have it.
Thank you, Bernard, for that fantastic talk. Do you mind unsharing your screen so that everyone
Yes, of course.
can,
Oh, where are we? It's just called share.
yeah.
Stop share. Okay, done.
Joyce, I'm going to hand over to you to facilitate the questions.
No worries. Thank you, Nalini. Thank you, Prof. So important that it's not only females calling out sexist patterns, but everyone and anyone. What a great example for all students and anatomists. So if anyone has any questions, feel free to raise your hand and unmute yourself.
Ah, Diogo, you're still muted.
I think Jose might have a question. Is that a hand up? No? Okay.
Diogo, I don't think you can hear us. You are still muted.
I think Andreas has a question in the meantime. I'll unmute you. Yep.
Okay, hi. I think Diogo doesn't speak with us, but with somebody else.
Okay.
I just wondered whether the term pubic has any connotations in English or Latin that are negative, because in the German translation it has.
Well, I don't know, actually, is the answer, Andreas, but it is something that I will look into. I can only look into it. I can't give you an answer. Does anybody have an answer to the etymology of pubic? If there are other questions, I can look it up initially anyway and see what it comes up. Do you know what it is, Andreas? No, you're muted.
Yeah, I'll hang on.
Yeah, well, I just looked it up, and pubic means pubis means something like manly but also strong. It has something to do with male sex, I guess. But that's all I know. I don't really speak Latin, so even though my father was a teacher of Latin, I've never learned it actually.
Well, it's worth checking up on that. I know the professor of Latin, not just at Cardiff, but also in Barcelona. So I'll check on it.
I think Pascal has his hand up.
Yes, I think, can you hear me?
Yes, we can hear you.
I think it means groin area in Latin.
Mm.
So it would refer to, I don't think it's related to any gender in particular.
Right, okay. If it did, of course, there would still be issues which we would have to consider, but it would be one stage different from pudere terms because it doesn't have a moral basis, whereas pudere terms have this moral basis as well as
Right.
the sexist basis. So my arguments, as I say, against pudere are sexism, yes, but also it's unscientific, and also it is not really a very good term biologically.
Bernard, we have a question in the chat. I'll read it out to you.
Okay.
So are there any other terms that we're not noticing but have the same sexist idea with pudendal? Are there any sexist terms that we should be changing? So this question came from Case.
Yes, a lot of people will talk about hymen and vagina. Vagina meaning a sheath, and there are issues about that, and Jenny might say that. Again, you may argue it does have a descriptive function, as opposed to a moral, shameful function. Yeah. So my arguments against pudere are related really to the fact that it is a moral vision or version which was brought to bear in the time when anatomy terminology was being developed and is no longer appropriate for the 21st century.
I think there's another hand up from Hasamuk, if you want to unmute yourself.
Yes,
sorry if I pronounced your name wrong.
I was not able to connect, but regarding the word pubis, we have been teaching that it means to be ashamed of, just like the pudendal or pudel. That is how we have been teaching.
I haven't heard, I just haven't heard that as being the derivation of pubis, but I will check on it. I will check.
Absolutely. We have been teaching like that. Thank you. Thank you.
I have a question for you. From your insights into this topic, how and what arguments would you put forward, in terms of balancing out the history of anatomy and then changing it to adapt to society's needs today, in terms of changing the terms and kind of like erasing the history? And should we erase the history?
No, well, yes, I've thought long and hard about woke and cancel culture, which is what you're referring to in some ways. People who use these terms are actually just using insults. It's like people who used to say do-gooders, in times gone by, as if we needed do-badders. So it's not really a rational viewpoint. I don't think you can ever cancel history in any way. It will always exist as an historical point of view. It is something which we should react against. Absolutely. By keeping it, we can say, this is how people used to be, in the same way as there used to be slavery. This is a term which used to be, we no longer can accept it as being an appropriate term.
Yeah, amazing.
There are always paradigm shifts. If you look at, in science, as Kuhn said, that in science, people work within set confines under acceptable paradigms, and then it takes someone to make a paradigm shift and everything changes. Well, people will fight like mad within the existing paradigms and don't like paradigm shifts. Conservatism and even reactionary attitudes will always exist. The question is, we would never move forward if we just have to kowtow to that kind of thinking.
Absolutely. There's a question in the chat from Amanda Meyer. Are the pudenda terms going to be changed by the FIPAT? What can we do to move this forward?
Beverly, do you want to answer that one? The executive committee have, I'll do it. The executive committee have said that all the terms should be changed. So they have changed it partially. It doesn't mean that that's the end of the story. But it is a political thing.
Okay. Are there any other questions? Any comments? Oh, we've got one from Natasha.
Hi, hello. Thanks so much
Hello.
Bernard, for the amazing presentation, also continuing the discussion and all the work that you did in this space. Really thankful to you. I'm sure everyone here is as well. I was just wondering if you have shared your arguments and responses to the arguments somewhere online. I don't get the opportunity yet to create content, but I teach content that's already created, and I try to teach it in a way that's inclusive. But I'd love to share the arguments and your responses to academics and just refer them to the resources and responses that you created. Have you shared those online somewhere?
Well, the papers exist, of course, and there is an interview which I can give you. You've got my email address, moxham@cardiff.ac.uk, and I can tell you the link with the interview with an American academic.
Yeah, because it was great.
And there is also in the European Journal of Anatomy, there's a head-to-head discussion with P.S. Brumont.
Great. And I think we have two more questions, very popular today. We've got one from Callie Spencer.
Thanks, Joyce, and thank you, Professor, for an excellent presentation. I was just wondering, if you do succeed in changing these terms, I mean, it would have quite a knock-on effect. You'd have to you'd have to approach all the surgical societies and all the textbooks that they're producing and journal publications, or maybe you could approach them even to help support your cause and help get these changes made even quicker. So that's what I wanted to say.
Yes, well, we have a draft of a letter to Lancet. So by writing to the major clinical journals to say what's happening in anatomy and with regard to these terms, that would be one stage further forward. And talking to younger clinicians, older clinicians probably will just not change, but younger clinicians are much more open to these kind of changes. But I think the way forward is indeed to contact the major societies and journals to indicate what's going on.
Absolutely. And I think we have a question from Jose.
Hello, good morning. Thank you for your talk. Can you expect a change in the near future, as most of the medical students are females? I teach to 70% of females at this moment, and most of the medical specialists will be females. They are around 50% now, and some specialties, male-dominated, are no more male-dominated. For example, they are orthopedists females, urology females. So I think things are going to change due to this tendency or not, this trend. What do you think?
Hopefully. But the questionnaire and the survey we did indicate that quite a lot of females are not aware of these issues, and even when they are aware, not terribly concerned. So yes, it is definitely one stage further on by having more and more females in disciplines which normally were male dominated. That certainly is going to be a driver of some change. But there are still other things we need to do. Attitudes need to be changed. People need to be aware of the issues. They're not aware of the issues at the moment. I mean, we're talking amongst ourselves now. Where does it go from here? How do we get it out to the students? Getting it out to clinicians, we've already said one way of doing it is to write to societies, write articles in or letters to the major clinical journals. How do we get to our students? How do we show them that these things are out there in a bad way and need to be changed?
Great. So if there are no more questions, I might hand it back to Nalini to introduce the next speaker. Thank you so much, Bernard. That was very insightful.
Pleasure.
Thank you very much for that presentation, really thought-provoking. And I'm sure there's lots of comments, and we will put up your contact details if people want to contact you directly. But thank you very much. Our next speaker is someone who probably has a long history in anatomy education, and that is Associate Professor Jenny Hayes. Jenny is from the University of Melbourne, and she's had a number of, I would say, career transitions in recent years, Jenny, but you probably will tell us a little bit more, and is now focusing a lot on looking at this aspect of female genitalia, and she will tell you more about that. So Jenny, I'm going to hand over to you to take it from here.
Thank you, Nalini, and thank you for giving me the opportunity to present, and what a great privilege it is to follow on from Professor Moxham's presentation. My specific focus is genital anatomy, so it's actually a perfect segue, and two contemporary challenges to genital anatomy. The first from the gender revolution, which I think Professor Moxham alluded to, and that challenges the discipline of anatomy, our traditional binary context of male and female and associated heteronormative presentation of genitalia and their function. And a second challenge from the expanding international market for female genital cosmetic surgery, which has highlighted the lack of accurate information on typical genital dimensions. Now, the most popular of the female genital cosmetic surgeries is labiaplasty, which involves cutting back the labia minora so that they sit flush with or are entirely hidden by the labia majora. And as you can see here, these are screenshots from actual websites from cosmetic surgeons. And you can see that they use the internet and social media to promote labiaplasty by pathologizing protruding labia. So in the bottom screenshot, you can see that the protruding labia is the before version. And then post-surgery, we have a tucked in appearance labeled normal. So inferring, of course, that this is abnormal if post-operatively we've got normal. And if you look at the screenshot above, you can see the use of words like repair and be well, rhetoric that really implies recovery from a pathological condition. It's been previously claimed that there is no evidence base for normal, but there are 10 published studies measuring normal genitalia in prepubertal and adolescent girls and pre- and postmenopausal women from 8 different countries and varied ethnicities that confirm and define the range of normal variation. And basically, labia minora can be long or short, wrinkled or smooth, dark or light, and are often asymmetrical. All of that falls within a normal range. The main functions of the labia minora are to protect the vaginal and urethral openings, direct the stream of urine, and contribute sensory and erectile tissue for sexual arousal. So this is really important information for our student population, given that in a recent survey in Australia, actually, where I'm from, 23.5% of labiaplasty is performed on females less than 25 years of age. So that's really our student population. But it's especially important information for our medical student population, given that in a recent survey, again in Australia, 97% of our general practitioners had been asked about genital normality. And we should remember, I'm certainly, again, I'm quoting our experience in Australia, there's no further postgraduate anatomy training for general practitioners. So what they are taught in their medical curriculum and what they experience in their medical curriculum is what they take with them to frontline consultations when they're answering these questions from their patients about genital normality. So the aim of this project, or the component of the project I'm presenting tonight, was to look at past and present representations of female genitals in anatomy texts to hopefully create the impetus for reimagining the spectrum of genital morphology in response to those two contemporary challenges. Descriptions of the labia and clitoris in the socio-political and scientific literature have in fact varied considerably over the last 200 years. So it's not immutable at all. And looking through the sort of socio-political and scientific culture over those centuries, there's been quite significant change. In the 19th century, anthropologists described labial protrusion as a feature peculiar to the non-white races. And then sort of subsequent to that, the medical literature shifted the gaze away from race, arguing that hypertrophy of the labia was the result of masturbation. In the 20th century, earlier in the 20th century, Kinsey shifted the focus away from abnormality to the role of labia minora in sexual arousal. And that really provided the impetus for the second wave feminist rebellion to create alternative feminist anatomies. And then in the late 20th century, and Professor Moxham's preceded me here with mentioning the groundbreaking work of Helen O'Connell, Australia's first female urologist, who used MRI technology to define the anatomy of the clitoris. And then, as I said, moving into the 21st century, we have the literal and figurative reconstruction, really, of female genitals by the female genital cosmetic surgeons and the gender revolution. So what I did was I analysed descriptive and visual portrayals of the vulva in historic and contemporary textbooks, and I was particularly interested in textbooks that were published in series. So I was looking over a period of time for change within those textbook series to determine whether these anthropological, sexual, feminist and surgical publications had influenced the content of anatomy textbooks at the time. And I suppose I was really looking for a precedent for change for the contemporary textbooks in response to FGCS and gender revolution. Now, I've only obviously got time to present just small snapshots of my findings. So the first finding I'm going to share with you was in Buchanan's Manual of Anatomy, a well-regarded text published in 8 editions between 1906 and 1950. And what I found in Buchanan's was that it directly referred to racially diverse labial morphology, the so-called Hottentot apron, which was observed by anthropologists in women from Southwest Africa, dubbed the Hottentots, and popularised by the denigrating display of Saki Bartman, a Khoisan woman paraded before the medical community and general public in London in 1910. Now, these images I've just included in my slide to illustrate Saki, that they're not from Buchanan's, but the text is. So you can see in the first 6 editions of Buchanan, they directly referenced this racial vocabulary being included in their scientific literature or the anthropological literature. If you looked under labia minora in Buchanan's in the first 6 editions, you found this description. They sometimes attain a large degree of development, in which cases they project through the urogenital fissure. In some African women, they become so much developed as to reach down to the knees. When this occurs, they form what has been called the apron of Hottentots. Now, between the 6th and 7th editions, so 1937 and 1946, there was a change in editor. And you can see that the reference to the Hottentots was removed, but the reference to labial protrusion was retained. So what you found when you looked under the heading labia minora was they sometimes attain a large degree of development, in which case they project from the urogenital cleft. And what I found really fascinating is this arrow almost exactly coincides with the publication in 1933 by Robert Latour Dickinson. Now, he was an American obstetrician and gynecologist and really self-appointed sex and marital therapist. And he published incredibly detailed measurements and illustrations of various hypertrophies in his patients, absolutely meticulous illustrations. But he postulated that all of these hypertrophies were acquired through or the result of masturbation. So it's almost like Buchanan's decided to take out the racial reference, but couldn't quite put in the sexual reference. I'm not sure. I'm now going to present to you what I found in Gray's, because really no anatomy textbook matches Gray's in terms of longevity and consistency of publication. And some of this Professor Moxon has already alluded to. In early editions, male genital structures were presented first, followed by female structures. And those female structures were defined by and compared to their homologous male structures. So you find things like the labia are analogous to the scrotum. The clitoris is an erectile structure analogous to the corpus cavernosum of the penis. Interestingly, remembering that the focus in the 20th century literature was on sexual function and the clitoris, it seems to have provoked, if anything, in other words, if I'm looking for a reaction in 20th century Gray's Anatomy to that work on the clitoris, it seems to have provoked a backlash of deletion. So if you look at the single black and white image of the vulva, included in Gray's Anatomy, the clitoris became less prominent and labelled less frequently in 20th century editions. So here we are in the 19th century, and as we move into the 20th century, you can clearly see that the clitoris diminishes in size, but also early in the 20th century, at least the components parts were labelled. But by the time we get to 1913 and continue throughout that 20th century, we're down to just a single label, clitoris. It also remained under the heading of female reproductive anatomy. So the headings in Gray's are male and female reproductive system. Obviously, that's still the case, and obviously that's problematic, as I mentioned, in terms of a binary presentation in this era of the gender revolution. But it was particularly non-reactive to Kinsey's work, because he put so much work in, and the feminist scholars as well, Kinsey and the feminist scholars of the time, reasserting the clitoris as the primary orgasmic site and outside of reproductive function. But again, it didn't move position in Gray's. Things have moved on, especially under the leadership of Susan Standring. And in the current edition, there's no homology between female and male structures. As you can see here, we've now got a new, and again, Professor Moxon alluded to this, a new multi-part colour illustration. And there is reference to changes with aging and variants of vulval morphology, but bizarrely, these are labium tertium, rarely reported. I could only find one paper, anatomical variation with a prevalence of 5.3%. Labial adhesions, which have an estimated prevalence of somewhere between 0.6 and 5%, and a peak incidence between 13 and 23 months of age, and postmenopausal females with severe atrophy. So that completely ignores the most common morphological variations and functions of vulval structures. I started to wonder whether anatomists and textbook editors even considered this as their remit, because surely by now, the first labiaplasty was in 1984, they'd be aware of the increasing social commentary around normal labia. And just to sort of give one more text from the research results of the contemporary texts analysed, only Moore's clinically oriented anatomy came close to providing the information on morphology and function required by our medical graduates for frontline consultations with females asking about genital normality and female genital cosmetic surgery. Interestingly, in the preface to Moore's, very clear about the remit. This book is written primarily for students studying anatomy for the first time, to cover areas that are most important for students to know. And there's a fabulous paper by Moore. It hasn't been cited very much. It definitely hasn't been picked up. It was actually based on an oration he presented in 1989 and then published as a paper called The Meaning of Normal in Clinical Anatomy. And he actually defined the areas that are most important for students to know. He said, students should be taught about the variations that are deemed likely to be of importance to the general practitioner of medicine or dentistry. And as I said, Moore's comes closest to equipping our medical graduates for those frontline consultations. It's not perfect though. Editions 1 to 3 actually described labial protrusion in parous women, but that was removed in later editions. A list of functions of the vulva was included from the 4th edition onwards, and editions 6 and 7, as you can see here, include multiple photos, but just of one vulva with protruding labia minora. Now, that's not unexpected because, as I've already told you, that's more common than not to have protruding labia minora, but the accompanying text doesn't reference diverse morphology. So my conclusion is that currently anatomy textbooks contain a binary presentation of genital anatomy that does not attempt to address issues of diversification, nor give a realistic view of what is normal for female genital appearance. So I use this slide when I'm lecturing the students. What's really important about the labia? They have a role in sexual pleasure. They protect the vagina from drying out and funnel the urine stream. For that function, they must be at least 1 centimetre in length. They can be long or short, wrinkled or smooth, dark or light, and asymmetrical, and structure changes with age. And every year I get enormous buy-in from the students and feedback and several emails like this. And I just thought I'd end by sharing this email from one student last year who had been taken by her mum to see the gynecologist when she was 13 or 14 years old. And as she said, during the examination, the gynecologist made a comment along the lines of, in terms of her protruding labia, presumably, if this becomes a problem later on, you can have an operation to remove it. And she said in her email, I was quite shocked. And ever since then, her comments stuck to me and constantly made me think that I had an abnormal labia. Your lecture today made me feel like I received that reassurance I honestly wanted from my gynecologist from 8 years ago. I think that's great reward for what's really one slide in a presentation. Thank you.
Thank you so much, Jenny, for your talk. It was amazing. And what a lovely comment to have from the student. All in awe of that kind of work. We do have time for some questions. Is there anyone who has a question to ask? Jenny, while we actually waiting for questions, I'll start with the first question. As you know, I have some big interest in this area as well. And for me, the challenge is we can educate our students, but there's the big lay public out there that still have these misconceptions. And it seems to be growing every day as issues of body image and all of that surface with younger people. Do you have any insight on how we can actually make a change in just lay culture?
Yes, so well, it's very interesting you said that. There's a lot of people working in that area, Nalini, and there's a lot of interventions being developed. There's some really interesting work too, just recently coming out of actually the Children's Hospital, that they looked at adolescents, but I think I'm presuming we can translate this. And most of the work is being done around education. And if we can get this message out there, then we'll turn the lay public's perception around and they won't be wanting labiaplasty anymore. But basically, they found that only about 50%, if you educate them, then went, oh, okay, I don't want a labiaplasty anymore. I know I'm normal. So there's what they call the D sisters and the persisters. And there's no doubt that, you know, a significant number will persist and in wanting the labiaplasty, because for them it's a cosmetic procedure and they just want a different or ideal labia. Reassuring them that they're normal, or reassuring them that they're normal is not the answer. So it's a big and complex picture, I think.
Absolutely, and you're right. It's more than just knowing that it is normal. It is rather than anything else. And I think while we're still waiting for questions, because I'm not seeing any hands up, please put your hands up if you do have a question, or drop a question into the chat line. I'm sure there's lots of things that this talk may have brought up.
Well, there is one other thing that I can quickly say then in answering that, the people that have looked at comparing penis augmentation surgery, or they've looked at that, if you compare that to female genital cosmetic surgery, one of the things that turns men off, I suppose, having the surgery is finding out that impotence is one of the side effects. So I think it's really important that we get out there that the labia minora have a function, and that when you remove that structure, you potentially remove that function. And I think that may potentially be an important key to the education.
Really good point. And I suppose we coming from the flip side of really looking at cosmetic surgeons and the kind of publicity that they put out around really promoting that idea that there is a normal that and a particular kind of appearance that is more appropriate than not. So there is also that kind of challenge to advocate for some kind of governance around that. And I don't know whether it's different in different parts of the world, but definitely in Australia, we do have a problem around cosmetic surgeons and the information that they put out and advocate. I see there is a question from Callie Spencer. And for those who don't know, Callie is a urologist. So he's coming with that kind of lens to this conversation. So Callie, yes, please go ahead. You have to unmute though, Callie.
There we go. Sorry, it wasn't allowing me to do it initially. Thank you, Professor, for the talk. It was great. I just wanted to go back to your comment on homologs, which was traditionally taught. Do you not still teach that when you teach the medical students, or do you teach it in a different way? How do you address that, just out of curiosity for my own teaching?
Oh, so actually my comment was around textbooks and so I was specifically talking to how they were presented in historic text. The male structures went first, were described in detail, and then the female structures went second. And very much, truly, in the early text, you would find, well, this is the equivalent of the whatever in the male structure. The nerve supply is the same as the male structure. The blood supply is the same as the male structure. So I'm not suggesting that drawing homologous comparison is a bad thing. I was really talking about the actual way it was presented and the fact that it was used to close down or minimize description of the female structure.
Thank you so much for that. I think that's all the time we have questions for. And Jenny, thanks again for an amazing talk, and the work that you're doing is of so much of interest to many of us on this call, and I'm sure you'll have many people contact you afterwards. But thank you for that fantastic talk. The next presentation that we have is really a bit of a short masterclass, and this is presented by Professor Beverly Kramer. It is looking at let's talk about sex and the determination of biological sex and the development of the genital system. I think, though, there may have been a slight refocus of that talk, just to bear with time. For those who don't know, Beverly Kramer is the president of the International Federation of Associations of Anatomists and a well-known anatomist, but also especially known for her work in developmental biology. Beverly, can I pass it over to you now?
Hello, everybody, and good morning, afternoon, evening, wherever you are. I'm delighted to be here and thank Nalini for inviting me to talk. Now, I think I'm talking to the converted in that most of you will know what I'm going to say. By the way, this is my University of the Witwatersrand in Johannesburg, and I'm going to cover a lot of what most of you as anatomists know. But I do understand that there are some younger anatomists in the group, and so a lot of this is directed at them. And then I'm going to speak on things that some of us may not know. And unfortunately, because embryology takes such a long time to explain, I'm not going to be able to talk about certain other developments like ligaments, descent of gonads, and most of the abnormalities which occur in this region. So I'd like to start, sorry, Nalini, I'm now having a problem with getting my slides to move. Here we go. I'd like to start with some definitions. I'm going to be talking about biological sex. I'm not going to be talking about gender, and I'm most certainly not going to be able to talk about gender identity today, because although there's quite a lot of information coming out on that aspect, we simply just don't have the time to talk. So I'm going to start far back in the early development and talk from fertilization. And here we see this beautiful photograph of an oocyte with sperms swimming all around it, almost at the time of fertilization. And then, as you know, when fertilization occurs, we have our sex determined. And just as a reminder, dad has X and Y plus 44 chromosomes, and mom had 44 plus X and X chromosomes. And with the division of these chromosomes into sperm and oocytes, we get an XX sperm, an XY sperm, another zygote. We would get an XX zygote, an XY zygote, another XY zygote, and a further XX zygote. So depending on what the chromosomal composition of our zygote is at the time of fertilization, that would be when our chromosomal or genetic sex is determined. Now, to tell you about the differentiation of the genital system, we do have to take a step back and speak a little about the urinary system as well. So I'm reverting to very early development, and most of what I'm going to tell you occurs within the first 6 weeks of development. This is a period known as the indifferent phase, because during this phase, we would not be able to determine a male fetus from a female fetus. So here in the urinary system, we would already have seen the development of the intermediate mesoderm into a series of structures which are going to form kidneys, the pronephros, the mesonephros, and later on a structure known as the metanephros, which will form our adult kidney. What is important to us at this stage is this tube, the mesonephric duct, which is forming from cranial to caudal and will grow in an inferior direction down towards the cloaca. Remember, the cloaca is a combined region at this stage, which has both gut tube and allantois opening into it, early stages of development. Remember too that these mesonephric structures will develop from cranial to caudal, and then they will also degenerate from cranial to caudal. In this next slide, we see degeneration of pronephros, further development of mesonephros, and now we see this mesonephric duct opening into the cloaca in a more caudal position. Note too, in this region, a massive mesoderm known as the urorectal septum is slowly dividing this combined cloacal region into two. And it will form a ventral urogenital sinus, into which we can still see the allantois opening, and then a more dorsal hindgut tube. But notice here now that as the division has occurred, this mesonephric duct, which will become important later during male development, is opening dorsally into that ventral UG sinus. If we look at a transverse section at approximately this level through the embryo, still in very early stages, we see in transverse section the neural tube dorsally, the gut tube suspended from the body wall by a dorsal mesentery. We see a very large fold on the dorsal body wall. This is known as the urogenital fold, and it is here that both the different types of kidney and the gonad are going to develop. We see here some mesonephric tubules developing, and on the lateral aspect, the mesonephric duct. We're still in the indifferent phase. Now, I'd like to remind you too about some other very important cells that are differentiating also in this indifferent phase, and these are known as primordial germ cells. These primordial germ cells are endodermal in origin, and they're arising in the region of the yolk sac. So that's miles away from where they actually want to be. They want to get to a developing gonad. So how do they get there? They will migrate from the yolk sac, through the yolk sac stalk, around the mesoderm of the gut tube, and I'll show you another photo in a moment or diagram in a moment, through the dorsal mesentery to get to the developing gonad, which is now going to be developing in relation to the mesonephros. So here's a closer look. This is a longitudinal view. Here, the yolk sac would be somewhere out of view, but now our primordial germ cells have come, managed to get into the dorsal mesentery, migrated through it, and they're popping in to a developing gonad. In transverse section here, we see this very broad urogenital fold coming off the dorsal aspect of the body wall. We see the gut tube in transverse section, the primordial germ cells migrating up, and they're fascinating cells that have been tracked by means of alkaline phosphatase in the early days and found to pop into this region on the medial side of the developing mesonephros. Here's mesonephros, here's the mesonephric duct, very far laterally placed, and these primordial germ cells now pop into a region of the urogenital fold, which is going to form the genital ridge. So again, what do we see as development proceeds? Primordial germ cells popping into this developing ridge. We now see that cords of epithelial cells are starting to project from the surface coelomic epithelium, so that's mesodermal, into the underlying mesenchyme here. And these primordial germ cells are going to come into contact with the coelomic epithelium. Notice again in this transverse section of the urogenital fold, that's this broad structure here. We have a genital ridge region. We have this major mesonephros developing, the mesonephric duct. But now we also see an additional duct known as the paramesonephric duct. And where does this come from? So let's concentrate on that paramesonephric duct now. This is a longitudinal view. We've got that gonad supposedly developing from the differentiation of coelomic epithelium and incorporating primordial germ cells. We can see the mesonephric duct growing in a caudal direction. And this paramesonephric duct now occurs by an invagination, again, from the coelomic epithelium in a caudal direction. And it will lie lateral to the mesonephric duct, and it will parallel the duct in its downgrowth towards the cloacal region. So at a slightly later stage now, we see that a gonad is developing on the medial two quarters of the mesonephros. There's a mesonephric duct on either side. It has grown down, and we said first opened into the cloacal region and then into the dorsal part of what will be the urogenital sinus. We now see a paramesonephric duct on either side, which has grown caudally as well. Notice that the two paramesonephric ducts approach the midline. In other words, they cross the mesonephric duct. They meet with each other in the midline and fuse, and then come into contact with the posterior surface of the cloaca. And this again, when separation occurs, this region will be in contact with the ventral UG sinus. Let me just point out that at this stage, the metanephros, the future adult kidney, is developing. So here we are at the end of the first 6 weeks of life. This, as I said, is known as the indifferent phase or bipotential phase. At this stage, we would not be able to phenotypically distinguish between a female and a male embryo. We could genetically differentiate, but not phenotypically. And if we look at the gonad at this stage, and this is taken from a mouse, We see the coelomic epithelium shown here in green, which is going to give rise to somatic cells. And we see those primordial germ cells, which have migrated in from the yolk sac, and those are shown in red. So a very, very indistinct gonad in the first 6 weeks of life. Right. So now, what happens now? So if we look at the male genital system, and Jenny, now I'm embarrassed to be putting the male genital system first, but it's easier to kind of explain, because what we know is that in the male, we have X and Y. Remember that during the indifferent phase, we produce 2 duct systems, a mesonephric and a paramesonephric system. So on the Y chromosome, we have the SRY gene, which is really the testis determining factor in male embryos. And the SRY gene is upregulated in the somatic cells that came from the coelomic epithelium, remember, and that produces SRY protein. The SRY protein then forms Sertoli cells, which secrete anti-Müllerian hormone. Now, a Müllerian duct was the old name for paramesonephric duct, but we still talk about the hormone as anti-Müllerian hormone. The anti-Müllerian hormone, which in the early 7th week after the different phase, will start to cause degeneration of the paramesonephric duct. So what we're going to see in the 2 sexes is that they both start off with 2 ducts, mesonephric and paramesonephric, but then in the one sex, the one duct system will degenerate and the other one will develop, and in the opposite sex, the opposite duct system will degenerate and the one will proliferate. The Sertoli cells will recruit mesenchymal cells of the gonad to form Leydig cells, and those Leydig cells will secrete testosterone. And in the fetus, the testosterone will promote the mesonephric duct, which will give rise to a variety of parts of the male system, as well as some of the texts say male differentiation of the brain. It's only at puberty, though, when testosterone surge occurs and the seminiferous tubules will canalize, and then spermatogenesis will start. And those, of course, come from the primordial germ cells, and the other sexual characteristics will start to develop. The production of testosterone leads to the formation of dihydrotestosterone. And this will cause differentiation of the indifferent external genitalia into a penis and scrotum. So DHT, or dihydrotestosterone, is important in virilization. And I'm really simplifying this all to try and get through it. What happens in the female genital system? Now, remember, in the female genital system, the genetic sex is XX. We said SRY was associated with the Y chromosome. There's no Y chromosome here. Thus, no SRY is produced. And in the old days, many taught femaleness as the default pathway of the human embryo. However, that is a total simplification, and we know today that this is not a passive process at all. So in the absence of the SRY gene, the somatic cells, again, I emphasize, which came from the coelomic epithelium, we'll look at them again just now. These somatic support cells will differentiate into follicle cells under the influence of the primordial germ cells, which will form oocytes. Again, we started off in the indifferent phase with 2 duct systems, the mesonephric and the paramesonephric system. But now in the female, as we enter into or past the indifferent phase, The mesonephric duct system will degenerate for the most part, and I must emphasize this for the male as well. The paramesonephric duct system will degenerate for the most part, but both of them leave little appendices, which we find in adult anatomy. Remember, there's no locally produced testosterone here. There's no anti-Müllerian hormone. And so the paramesonephric duct system in the female will persist. And again, it is the lack of androgen exposure which will result in a female genitalia. But again, I'm obviously oversimplifying. Here are some of the genes. And again, I refer you to text if you would like to go more into the genes that cause differentiation. I've just tried to summarize them here for you. At this time, when differentiation of the gonads is going to start occurring, we find SOX9 and Wnt4 in the gonadal ridges. Now, in the male, the presence of SRY, remember coming from the Y chromosome, the SRY gene, is going to inhibit Wnt4, but upregulate SOX9, which in turn will activate other genes to cause testis differentiation. Again, I emphasize this is a great oversimplification. However, in the female, the Wnt is present, it hasn't been inhibited. It will cause upregulation of DAX1, which inhibits the SOX9. Remember, SOX9 appears to be responsible here in a large part for testis differentiation, but in the female, we're seeing inhibition here. There's upregulation of a variety of other genes, and ovarian differentiation will ensue. So let me take you back to this beautiful slide from Schoenwolf et al., in which we look at the gonad in the mouse in the indifferent phase, which was pretty undifferentiated. So it could be in an XX fetus or embryo, sorry, or an XY embryo. But now with the presence of the Y, which gives us the SRY, we see that the coelomic epithelium arranges itself into cords. There's the green, and we see the primordial germ cells being incorporated in these cords. In the female, which is lacking the SRY gene, we see the somatic cells forming follicular cells are really being arranged in a circular fashion, incorporating a little red primordial germ cell within it, excuse me. So how does the gonad in the male and the female morphologically then differentiate further? So on your left is the male, and here we're finding that we saw the cords of coelomic cells containing the primordial germ cells forming to form the gonad. But in the male, remember, we're going to see degeneration of the paramesonephric duct and persistence and development of the mesonephric duct. And what happens is there are connections formed between these coelomic cords, or testis cords, if you'd like to call them, with the mesonephric tubules, and the mesonephric tubules are opening into the mesonephric duct. Let's concentrate on this male just for a while. Here's the coelomic cords, which will form seminiferous tubules of the gonad later on. They will connect via the ratate testis, and all these parts, mesonephric tubules, will give rise to the ductuli efferentes, and these open into the mesonephric duct, which is the epididymis, and the rest of the mesonephric duct will form the vas deferens, which I showed you was opening into the posterior part of the, or should I say, dorsal part of the cloaca, which will become the dorsal part of the urogenital sinus. What happens now in the female? Well, no SRY in the female, no anti-Müllerian hormone. So the mesonephric system will degenerate, but the paramesonephric duct will persist. Here are the somatic support cells forming follicle cells containing the little primordial germ cells, which will form an oocyte. And as development proceeds, there'll be degeneration of all the mesonephric parts, and a little ovary is established. We see fimbria and an opening into the paramesonephric duct. Why is there an opening? Because remember, there was an invagination from the coelomic epithelium into the surrounding mesoderm to form the paramesonephric duct originally. So there's the fimbria around the ostium of the uterine tube, and the paramesonephric duct will form the uterine tube, here labeled oviduct. These little remnants, and I'm not going to deal with them, are remnants of the paramesonephric system, and those give rise to a variety of little appendices that we find in adult life. And again, just here to show you, although I'll go into it in more detail later, sorry, if we look at the green ducts, those are the paramesonephric ducts which first fuse and then open into the posterior part of the cloaca. Let's look at the female genital system in transverse section, because here we can see some other important features. To orientate, again, transversely, there's the neural tube. Here's a gut tube with its dorsal mesentery in transverse section. Here's the urogenital fold. We can see a degenerating mesonephros. We can see the gonad, or developing gonad, in this case, an ovary in the female, and it's occurring on the medial surface of the degenerating mesonephros. And look at the duct systems. There's the mesonephric duct. There's the paramesonephric duct lateral to it. Now, as these grow and as they go more and more caudally, we see that the two paramesonephric ducts move far medially, where they will fuse and form the upper or superior parts of the uterus. And we'll come back to this in a moment. Notice the position of the gonad, although I didn't want to go into this too much here, we don't have time. Notice that the mesonephric duct is regressing. So here in a sagittal section, let's re-look those paramesonephric ducts. We said there were two paramesonephric ducts, which are coming down in a caudal direction. They contact the posterior aspect or dorsal aspect in the embryo of the urogenital sinus. And as a result, they cause an upgrowth from the urogenital sinus known as the sinovaginal bulb. This sinovaginal bulb will then grow in a cranial direction, as it were, pushing the little fused tips of the paramesonephric duct slightly more cranially. Before we go on with that, I would just like you to look at this region here, and we'll come back to it when we look at the external genitalia. But remember, I said that the cloaca was separated into two parts, the dorsal gut tube and the ventral urogenital sinus. How did that happen? There was the downgrowth of mesoderm, the urorectal septum, and eventually fuses with the membrane in this region. Sorry, if I can just go back to, and the membrane, you will remember, is a cloacal membrane, and where the urorectal septum fuses with that membrane, we'll get the perineal body forming. And the perineal body is separating off the anus from what is the urogenital sinus. And I want you to watch that area because as this region grows and spreads outwards, we're going to get separation and opening of 3 regions now. Let's just return for a moment here. So what we've seen is upgrowth of the sinovaginal bulb, canalizing, and there's canalization of the paramesonephric tubes. So we get the unpaired paramesonephric duct on either side, forming the uterine tube. We'll find that the fused paramesonephric duct on either side will form the uterus, and then a lower part of the fused paramesonephric duct, together with this canalized part, the upgrowth from the back of the urogenital sinus, will together form the vagina. Okay, now as this region opens up, remember anus there, and then we got to get separation of this vaginal opening from the rest of the system. Notice now that there is the opening into the vestibule of the vagina here, and over here we will further get the opening for the urinary system. So we have separation into 3 regions. Perhaps easier to see now in these colored diagrams, although they don't take the development as far. Urorectal septum growing down to separate urogenital sinus from cloaca, fusing there eventually with a cloacal membrane to form the perineal body, and then separating the urogenital sinus, which will develop into bladder, and the urethral portion of the urogenital sinus from the anus. In the male, we see the ureters, which are going to be pushing that metanephros up into its adult position. And then we see the persisting mesonephric ducts, which open into the dorsal part of this urogenital sinus as the duct system of the male. In the female, we've found a separation of the urogenital sinus ventrally into 2 parts, the vagina and uterus, and from the urethra, which will open from the bladder, and those 2 urogenital sinus separated from the anus. Right, very briefly now, I'm going to deal with the external genitalia. I'm not going to go into details of development of the urethral plates. I'm going to focus mainly on the soft external genitalia. And when we look at this in the indifferent phase again, what we see is a region where there's been a buildup of mesoderm. And where's this mesoderm come from? It's really mesoderm flowing in from the primitive streak and surrounding this region known as the cloacal membrane. You'll remember that cloacal membrane occurs, or a membrane of this kind, occurs where ectoderm and endoderm come directly into contact, no mesoderm intervening, and eventually the membrane will perforate. But there's heaping up of this mesoderm around the opening or the potential opening, and this will form 3 structures: a little genital tubercle, more cranially. More laterally, we'll find a urogenital fold or genital fold, and more laterally still, heaping up of mesoderm into 2 genital swellings. So in the early 7th week, so we're moving out of the indifferent phase now, we see a bit of elongation of that genital tubercle. I'm not, as I say, going to deal in the details of this, but we see that there's some growth of the urethral folds to close over this little groove. Let's look then at what happens in a female fetus at this stage. We see that there is little growth of the genital tubercle, which tends to be directed more caudally. The genital folds will grow on either side, but will not completely close the opening into the vestibule. And there's some enlargement or some swelling of the genital swellings. So the genital folds will form the labia minora, and the genital swellings, the labia majora. There's the anus separated from the vestibule by this perineal body that formed, and there's the little glans clitoris. In the male, and again, I emphasize, I'm not going to the details, we see very beautifully there's an elongation of these genital folds, as can be seen here in this scanning electron micrograph from Motter's book. And there will be closure or fusion of these genital folds, and the genital swelling will grow, increase in size, whereas the genital tubercle will increase in size, and the genital swellings will fuse to form the scrotum. Right, so now we come to what I think fits in well with the rest of the symposium this morning, and that is talking about diversity and sexual differentiation. And remember, I'm going to be talking mainly about biological sex. And the first variation I'd like to speak to is Turner syndrome, which is well known to you. Its chromosomal complement is 45 and an X. In other words, there is a missing X. And what we see in individuals affected by Turner's is that they're short in statures with very broad chests. They have dysplastic gonads. The nipples are widely separated, broad chests, short in stature, as I've already said, and very typically they have this webbing of the neck. So that is due to that loss of the X chromosome. Then there's another syndrome I thought I should also mention, because this one is quite common. You can see the frequency is 1 in 500 to 1 in 1,000 males. The chromosome complement 47XXY. And this is known as male hypergonadism today. And there are a number of defects as well, as seen here, that occur in these individuals. The next grouping I would like to deal with are the groupings of diverse sex development, which today is also known as intersexuality or intersex. And as you can see from the statement, this will include individuals born with any of several sex characteristics, including chromosome patterns, gonads, or genitals that do not fit typical binary notions of male or female bodies. And what we're going to look at really is a spectrum or continuum. So let's deal with the first one. And this is now known as over-testicular diverse sexual differentiation, the DSD, also known as intersex, formerly called true hermaphroditism. Why was it called hermaphroditism? Because in Greek mythology, Hermes had fused with a sylph and then had gonads that showed both male and female components. So true hermaphrodites or over-testicular DSD show both testicular and ovarian tissue, but they have a variable phenotype. And I always find the histology of the gonad very fascinating, because we see not only the oocytes in their follicular surround, but in the same gonad, we also see beautiful seminiferous tubules. And these gonads, or should we say over-testes, are generally of the unilateral type. What do I mean by that? Mainly that an over-testis will occur on one side and a normal gonad on the other. And testing for testosterone will indicate or does indicate that Leydig cells are present. There has been in the literature evidence of ovulation in these individuals with over-testicular DSD. And also, if we look at the spectrum of intersex, true hermaphroditism is the rarest form. There's about 1.7% of the population which have these intersex traits. So here are some of the features of true hermaphrodites or intersex. They have a variable carrier type, as you can see, varies from 60% with 46 chromosomes having that XX complement to a 46 which includes the XY male complement. And this is quite an interesting paper that I'd like to refer you to by Nistel. You'll pick it up in my references at the end. There's generally a uterus present. The external genitalia are ambiguous or female. The cause, I believe, is still poorly understood, normally a mutation in the SRY gene. It occurs, as we've said, according to Nistel, in 10% of the population, and the phenotype will vary greatly. I'd also like to talk about pseudo-hermaphrodites, although in the literature, there's a bit of controversy as to whether these are incorporated into intersex or not, but I'm going to discuss them here today. So, sorry, I've lost my cursor for a minute. So what is a pseudohermaphrodite? It's an individual in whom the gonads are consistent with chromosomal sex, but who has external genitalia of the opposite sex. So for example, if a testis is present, the patient will be called a male pseudohermaphrodite. There's inadequate production of testosterone and normally inadequate virilization of the male fetus. So they may have a Y, they may have a testis, but external genitalia will appear of the opposite sex. If the ovary is present, the patient is called a female pseudohermaphrodite, normally caused by exposure to excessive androgens, generally associated with a congenital suprarenal hyperplasia. And so we have an ovary, a female genotype, but masculinization of the external genitalia. So how do female pseudohermaphroditism and male pseudohermaphroditism occur? According to Horry, there can be a variety of ways, either, as I've mentioned, the suprarenal hyperplasia, exogenous androgens, which may affect the fetus, maternal ingestion of androgens and progestogens, virilizing adrenal or ovarian tumors, excess placental androgen production, placental P450 deficiency, and in the male, impaired Leydig cells, defects in testosterone, and Leydig cell hyperplasia. So here is a female pseudohermaphrodite, so chromosomal complement XX, as I've said, commonly caused by suprarenal hyperplasia. She has an ovary, but she has excessive production of androgens, which has caused masculinization of her genitalia with a fusion of the labia majora to indicate a scrotum and also an enlarged clitoris. Again, another case of a female pseudohermaphrodite. I remind you, genetic sex, XX, masked by phenotypic sex. This is a 6-year-old female. She has an enlarged clitoris, fused labia major, and you can see that better in this photograph, indicating a scrotum, and that little arrow is just indicating where the folds haven't fused properly, and there's an entrance into the UG sinus. So this is a form of male pseudohermaphroditism, and this is known as androgen insensitivity syndrome. The individuals will have a 46XY karyotype. but they have female external genitalia, as you can see from the individual pictured on the left. If we look at the histology, there's no germ cells, there are only Sertoli cells in the seminiferous tubule. And the problem here is that the androgen receptors are absent, so there are high levels of male steroids, which the fetus will not then respond to, and the development will proceed as though the androgens are absent. And I'd like to end by saying this quote from Frederick Hopkins: "A cell has a history. Its structure is inherited. It grows, divides, as in the embryo of higher animals, the products of division differentiate on complex lines." And I think for humans, the emphasis is complex. Living cells, moreover, transmit all that is involved in their complex heredity. The human being is, after all, a human, complex, beautiful structure. Thank you for listening. I hope I've made some sense of the topic.
Thank you, Professor Kramer. That was amazing. I'm sure for a lot of us who know embryology, it was inspiring to watch how you teach it. And for those who perhaps needed some revision in embryology, I'm sure this was the perfect lecture or masterclass. So we have a few questions in the chat. I might read them out to you. So the first question is from Jamie Chapman. So recently a relationship has been suggested between anti-Müllerian hormone and development of polycystic ovary syndrome. I was just wondering if you knew much about that. Is it a result of a minor form of masculinization of the otherwise female fetus?
So, confession, I don't know much about pathologies that occur. We do have, I hear, a urologist on the line with us, and maybe he knows more about that than I do.
Okay, no problem. Can we just, before we move on to the next question, can you just stop sharing your screen, please?
Okay, here you go.
Yes, thank you so much. All right, great. And let me just scroll back. There was another question. There's a question from Amanda Meyer. The outcome that I want to know is, what are we going to rename male and female reproductive system chapters? What terms should replace female and male?
Gosh, Amanda, that's a hard one. Yes, I agree with you. We don't want to stick totally to the binary, and we do want to show that there's spectrum. So possibly we should entitle the chapters dealing with male and female systems as a continuum of genital systems or something like that. But you as a young person may come up with a better term.
All right, great, thank you. I think Nalini had a question. You're just on mute, Nalini.
Am I still on mute?
No.
Oh, yeah. So thank you for that talk. That was excellent. My question is around terminology. It always comes back to that eventually. And the term hermaphrodite, and whether that is a term that we should use, or whether there are other terms that we should be using. So around that terminology.
So I think the pathologists have now started using the term intersex for true hermaphroditism, and I agree with that. It's harder to suggest a change in terminology for a pseudo-hermaphrodite. I'm not too sure what could be suggested for that. And as I said, because of the controversy as to whether it falls within intersex or not in the literature, that is why you still find the term pseudo-hermaphrodite in the literature.
Around these terminologies, as we use them a lot in education, and like we spoke earlier, we want to actually inform the next generation so that they can, and whether we should be doing something around that. that's my comment.
Sorry, Nalini, I think the sound came through halfway through your question.
I think I have a question. It was just a comment that maybe we should be putting together some recommendations around terminology as we want to inform and discuss with the next generation so that they could advocate for change.
Absolutely. Thanks, Nalini. Does anyone have any other questions or comments they would like to make? Yes, Callie.
Sorry, I'm not a pediatric urologist, but I just wanted to say that, yeah, we try not to use the term pseudo-hermaphrodite or hermaphrodite anymore, but rather would say 46XX DSD or 46XY DSD, or masculinized female or under-masculinized male. So that's what's in our textbooks, at least. I don't know. Yeah, that's from a urology point of view.
Thank you. I think that's great. And perhaps we should see that these terms are now start being introduced into our anatomy texts and also the embryology books.
It always comes down to embryology, huh?
Yeah, I also wanted to say, yeah, I mean, I've been trying to, I mean, I still call things male and female, and then I always put like a little disclaimer at the bottom, male referring to assigned male at birth. You know, there was a question of, you know, well, how should we address this? And I think Jenny had also said there, you know, moving away from the term genital or moving away from the term reproductive as well, because that's also controversial. Yeah.
Well, you know, it's an opportune time for a committee like FIPAT to set up a little subcommittee now to deal with some of the issues that are coming up around diversity, and for them to discuss and engage with younger people who have this interest to lead us in the new terminology. I think that's important.
Sounds like a fantastic session. Thanks, Joyce. Professor Kramer, thank you so much for your talk. It was excellent. And as you can see, has raised a number of questions and questions that, you know, we all who are teaching in this area are grappling with it all of the time. So it'd be really good to think about speaking widely globally and having that kind of consistency, but also advocating for the future. So thank you very much. That was excellent. Our next talk is by, I'm just trying to see if I can see Federica here. Yes, Federica Sacco. She's going to be presenting on behalf of Gianni, and he's got a poster on diversity in the Museum of Human Anatomy at the University of Pisa. Federica, unmute yourself and so that I can just get you on screen.
Yeah, good morning from Italy. I'm here in Pisa, and I'm here, as Nalini said, on behalf of the director of the museum, Gianfranco Natale, who is engaged in another institutional activity. So can you see me?
Yes, we can see you.
Okay. Okay, wonderful. So first of all, I want to thank you so much to have the opportunity to participate to these interesting anatomical connects. And I really appreciated the other contribution because they were also interesting and important to understand the topics of today's symposium. I'm very happy to be here to illustrate to you the diversity in the Museum of Human Anatomy Filippo Civenini of the University of Pisa, because it offers different examples, positive and negative, concerning the attention paid to diversity in anatomical teaching and research. So there were three famous anatomists who gave a crucial contribution to the history of medicine here in Pisa: Andrea Vesalius, Rialdo Colombo, and Gabriello Falloppio. They all carried out important anatomical studies on female corpses. They lived during the Renaissance, a period characterized by a revival of classical learning and renewed interest in wisdom. And as we can see here on the poster, I don't know if it's up to presentation.
Can you see the poster?
No, we can't see the poster.
Okay, wait, I'm going to try again. Just give me 1 second to see if I can share it again with you. Can you see that now?
Still
not.
No.
Not yet.
Okay, if you can, I'll try and get it up in a moment. You probably need it. 1 second.
Okay, so now I can see it. Thank you very much. I'm sorry about that. Yeah, thank you. So, as I was saying, as we can see here on the cover of Vesalius' masterpiece, De Humani Corporis Fabrica, is in the first top half of the poster. It's the fourth image from left. As you can see here, on the cover of Vesalius' masterpiece, De Humani Corporis Fabrica, published in the 1543, there is a female corpse on the dissecting table, and that was something new for the time. And as we know, that volume was a milestone in medicine, typography, and science history, where for the first time in the area of medicine and anatomy, Galeno's dogma was previously proved to be wrong. And also Vesalius was the first to study the female body through anatomical dissection. And in fact, in his epistle on the China roof, he reported dissection on nuns just when he was here in Pisa. Also, Realdo Colombo and Gabriello Falloppio work was majestic because they contended for the description of clitoris. And more precisely, Colombo seems to be the first to use the word placenta. Now, moving on the second half of the poster, we find negative examples of anatomical attention to diversity. We are later in the Europe of the 20th century. Because in the anthropological collection of our museum here in Pisa, there is a beautiful wax model of a young man that refers to a South African ethnic group, historically known as Hottentots, and you can see it on the left. And this model let us examine the dramatic history of this population that between 1904 and 1908 lead to a genocide by the German Empire during colonial occupation of Southwest Africa. And unfortunately, this is considered the first genocide of the 20th century. There was a foretaste of the genocide of the Jews that happened during World War II. Moving in the last part of the poster, at the bottom, we find Francis Galton that in the 1883, he coined the term eugenics. Francis Galton was the cousin of Charles Darwin. And this concept, eugenics, was developed largely by Galton as a method of improving the human race and was increasingly discredited as unscientific and racially biased during the 20th century, especially after the adoption of this term by the Nazis in order to justify their treatment to Jews, disabled people, and other minority groups. In conclusion, referring to the 19th century, in our museum, there are some phrenologic maps originated from the theories developed by Franz Joseph Gall, a German-born physician, and Italian scientist Cesare Lombroso and Paolo Mantegazza. And as we know, phrenology was a field of thoughts based on the idea that the brain was the organ of a person's mind, and personality traits were all located in a separate area of the brain and could be measured by feeling bumps or fissures of a person's skull. We find an historical example of its application during the 1830s and 1840s when phrenology became popular. Like in the US was struggling in that time to justify the continuation of slavery in the face of a growing abolitionist movement, and was dealing with interaction between white Western settlers and existing Native American population. And in the case of slavery, physicians used phrenology to attempt to prove that African people and Native Americans were in the rightful place as slaves. The view of people of African descent as inherently mentally inferior contributed to the continuation of slavery and the segregation and racism that still persist in the US. So phrenology during the first time of the 19th century and arguably beyond offered a clear-cut explanation for why people behaved the way they did. And it was hailed by many as an extraordinary effective explanatory tool that led to racial issues and stereotypes. And I want to thank you for your attention and remind you that the Museum of Human Anatomy of our university also has a video on YouTube where you can have a little virtual tour and introduction of our exhibition. And you can find the link on the top left corner of the post that I've just presented. It's just on top. Thank you so much.
think Nalini might be frozen, but thank you so much for that presentation. So now I think we have a couple of minutes to take any questions if anyone has any. Just pop your hand up. Yes, Natasha.
Oh, thank you so much. That was such a great presentation, Frederica, and super interesting depictions you shared. I was just very fascinated by the examples you gave of female genital depictions. And I was wondering, how do you think how these genitals were depicted influenced how we talk about genitalia now? And in particular, if you have any comments about how we communicate or how genitals are communicated in Italian culture as well.
Yeah, thank you for that question. I worked with the director of the museum, Gianfranco Natale, and he showed to me that the history of anatomy is a male history, and just in the Renaissance it was so innovative and so new to find the representation of a female corpse. And now in Italy, I think we are trying to make some step forward to be more representative, even on the anatomical aspect. But I think we have a lot to do. We are not arrived to a decent point yet, in my opinion. But we are trying to get in there. Yeah, I think it's not something relegated to Italy. I think it's like a global movement that is trying to take one step forward to have simply a more representative system. Yeah. So we especially in Italy, we have a great history of innovative perspective, and I hope that also in the future we can continue that.
Amazing, great. Thank you so much. Does anyone have any other questions? I have one for you. You mentioned that the museum is available virtually online. I was wondering if, throughout the pandemic, and sorry to mention it, we almost made it through one conference without mentioning the pandemic, if it has been used a little bit more than usual, or if the use of it has been decreased. Do you have any data regarding that?
Yeah, during the pandemic, it was very hard. We were closed, but now we are trying to get back. People are coming to visit our museum, but we produced that video also to continue to represent our museum even when it was not possible to be here in person. It was a great tool to even let the people know about it, about our museum. Now we are good. We are in a good place concerning visits and participation. But it was a really hard time, yeah, during the last 2 years, yeah.
Yeah, and I'm sure people would have used it looking for activities to do on the weekend or on weeknights, not being able to go out. Yeah. So that's great to hear that everything is well again.
Yeah, slowly we're coming back. Yeah.
Does anyone have any other comments or questions? If not, thank you again so much for your talk, and apologies about the technical difficulties, but we made it. I might hand it back over to Nalini now.
Thank you so much, Joyce, and thank you so much, Federica. Sorry, I dropped out because of my internet issues on this side, so hopefully I'm going to make it to the end. Thank you all who have made it right until the very end. We've got one more segment to go, and then we will probably be closing probably in the next 15 minutes. So I want to firstly thank everyone who presented today. It was such a fantastic spread of talks and also of conversations, and lots of these conversations are starting point for us to do much more work in this area. So thank you, everyone. And for those of you who can, please give all our speakers a clap. You can use the reactions icon in your thing, or you can actually just clap. That's fantastic as well. So thank you, everyone. Fantastic. As you know, we have been doing a little bit of a theme from October to now, and it was around diversity, inclusion, and accessibility of anatomy. But as we go into next year, we will be talking about slightly different things, but not completely leaving this behind. You know, everything is related. Anatomy is about relations, and so every conversation leads to another conversation. I'm going to try and share my screen for a moment so that you can see some of the stuff that we have for you. Let me know if you can see that screen. Can you, Joyce? Fantastic.
Yeah, we can see it.
So that finally means that my internet is working. So what I did want to show you is that this is the Anatomy Connects site. It has on it a whole lot of teaching resources, and we're hoping to build this collection as time goes on. So if you do have some teaching resources that you would like to share with the wider global anatomy community, we would welcome that. There are many people in regions that are not as resourced as others who really would value this. So please do put some of those things. If you send them to me, we will put them on. We have a whole lot of contributions around the research and scholarship in anatomy. And so if you do have short presentations of 5 to 10 minutes, their videos, their presentations, we review them. And if they meet certain criteria, we put those up as well as discussion points. So that's something that you can also see in there. We also have, if you have published a paper and you have a DOI link for your paper, then we will promote that paper on this site as well, provided it is a peer-reviewed published paper in a journal. So we're very happy to do that as well. And like you can see, the poster that was presented just now is here, as well as that link to that video that tours the museum itself. If you go and have a look at that video, you'll see it is a fantastic tour of that museum. And because there are many of us that can't go to Italy in the near future, it is a fantastic way to still visit a museum and see some of the things that are related to anatomy and in the widest form, including biological anthropology. As much as we have all of those, we also do want to celebrate creativity in our discipline, and what a creative lot of people anatomists are. So if you do go to the site, you'll also see that there are artworks that we have put up, and there are a number of different artworks that you will see on the site. So please do have a look at them. There's a little write-up about those little artworks, and so that's also really interesting about what the artist had intended. Along with that, you'll see not only artworks, we also want to celebrate those of us who are gifted in poetry and so forth. And so you'll see there's a number of poems and things up on that site as well. We're hoping that it will become a site in which anatomists from across the world will find and share resources with each other. Now, a few other things to just tell you before we close. And of course, there is some very exciting things to say. So this was the Anatomy Festival of 2021. We will be leaving 2021 behind, much to the joy of some of us, and going into 2022. And we're hoping to have good times then as well. We did run this festival, and we said that we would have a number of awards, and we have actually made some of those awards, and I'm going to announce them here today. And after this session, you'll get a little email from me just reminding you of your award and what that was about. So when we started talking about awards, we had lots of discussion about what the criteria for these awards would be. And as you know, the first pass of anything is probably a big learning curve. And for us, it was that. And I think for you as well, dealing with us is probably a bit of a learning curve. We've made awards in two categories this time. One is the Creative Award, and the other is the Research Awards. And you'll see what that is just now. In the creative category, there was, like I showed you, there was a number of submissions. And our focus in this year has been around diverse, inclusive, and accessible anatomy. And for that reason, although we had marvelous contributions, we tried to focus and award those that actually focus on those themes. So there's a few mentions that I'll make, and then I'll tell you who the winner is. And it's really because of that theme and how that art actually filled the theme. So there is one, and this is by a 5th-year medical student from Ukraine, fantastic drawing, and we really, really admired that story behind that drawing, but also the painting itself. There was another from Turkey, as you can see there. And then really, when we judge these, we judge about how much they actually aligned with the theme. And the two that are winning, this is a runner-up, and we wanted to give it a good mention. This is from Pascal Karib in Australia, and Pascal is on this call. So thank you, Pascal, for the submission. It was one that we wanted to give an honorable mention because it did actually celebrate diversity and inclusion and was fantastic. In terms of that. The two winners, though, there's a joint winner. The one was this also from someone in Australia, Christina Bayun, and it was around that pelvic anatomy, and she had a lovely story to go with why she had drawn that, so that was fantastic. And then the joint winner with that is really a fantastic piece of artwork. It is not drawing, but it's really felt work, and that's by Jeanette Phelps from Scotland. So congratulations to the winners. You have really stimulated us with your creativity, and we absolutely loved looking at all of that. And we will actually leave them on the website so you can see them for a little longer. In a similar way, we had a number of contributions that were in the research category. And because this category was around research, we were looking at people who had a research lens into how that presentation was made. So not just a description of something that was being done, but really looking at some research around anatomy and scholarship of anatomy education. There's two that we actually chose as joint winners. And again, they're different, but they had really marked all of those scientific criteria that we wanted. The one was using pre-work traffic light system to prepare students for active learning. This was a wonderful little contribution from Rachel Dorr from the United Kingdom. She presented some work about just how she used the traffic light system, red, amber, and green, to show students the work that they had to do before they came into the lab. And it was a wonderful bit of work that lots of us can actually translate into our practice. The second was looking more at higher degree and postgraduate and research students and how to support them during the pandemic. And that was from this multidisciplinary team from South Africa and Namibia. And it was a really good presentation around transforming their journal club into a virtual journal club in anatomy. So both those presentations are up on that Anatomy Connect site, and please do have a look at them. They're fantastic. Anatomy Connects, though, is not over. If you have presentations on our next theme, we would welcome them. Please send them whenever you have. We'll put them up and we'll promote them through our different media. And of course, towards the end of next year, we will look at evaluating those if you want to enter them for these awards. A few things to tell you that's coming up, which I thought would be wonderful. Of course, we do have an IFA conference, which will hopefully be in person. So please make sure you keep yourself alert for that information. And that is going to be the highlight, of course. But in between the year, we do want to continue these conversations that we started. These resources from today, the talks, as well as the contributions that we had via submissions over the last 2 months, as well as the talks from the first symposium, will all be up on that Anatomy Connect site. You will also get an email from me just reminding you where the site is of the videos when they are released. And a very important piece that follows is a discussion forum that we're hoping to release before the end of the year, where you can actually continue these conversations through discussion throughout the year at any time, a platform that's very similar to WhatsApp, but is really a platform that we can talk and have a category kind of a discussion going through it. And I'll walk you through how we're going to do all of those kind of things. Next year, we will continue our symposium series, and there's 3 themes that we've picked. One is active learning, because we know that it's really important for students to be active in their learning so that they learn deeply. The others is digital technologies, because I think we are in an inflection point in all of society, but also in education, and digital technologies is going to be important. But we want to look at not just technologies, but how do we use the technology properly so that it is actually useful for people as they want to learn. And the last thing, because as we saw today, so many things around anatomy and terminology is related to society and how we think about things, we do want to talk about humanistic anatomy education. So those are 3 things just for you to reflect on during the summer, winter, depending on where you are, holidays, and think about what you may want to present or submit to us for presentation. So thank you, everyone. Once again, it's been a fantastic evening for me, morning for you, or afternoon for you. It's been lots of discussion, and I think lots of things for us to think about as we go into 2022. So good night. I want to wish you all the very best for the new year, and we will see you in 2022. Thank you. Bye, everyone. Thank you, Joyce, for helping me tonight. It was fantastic as well.
Thank you.